It's Dmitry again. Today we'll be going back to the Mehlman Medical Internal Medicine PDF, now looking at Internal Medicine General Pathology. So this is a relatively short chapter. It's about 10-ish pages. I think it's a little bit longer than that, but it should probably be just one video. So let's begin. Internal Medicine General Pathology. High-yield cancer genes, APC. Mutations cause familial adenomatous polyposis, or FAP, chromosome 5, autosomal dominant. Hundreds to thousands of polyps on colonoscopy, 100% cancer risk. That's pretty crazy. Answer on 2CK form is total proctocolectomy in 18-year-old, presumably since 100% chance of cancer, plus too difficult to conservatively screen. FAP positive, FAP plus soft tissue, lipoma, or bone tumors, that is to say of the skull, equals Gardner syndrome. FAP plus CNS tumors equals Turco or Turcot syndrome. BCL2. Overexpressed in follicular lymphoma, most common indolent non-Hodgkin lymphoma as a T14-18 translocation. Codes for anti-apoptotic molecule. Follicular lymphoma will present as a waxing or waning painless lateral neck mass over 1 to 2 years in an adult. USMLE might give you a research type question where the BCL2 is overexpressed, unrelated to follicular lymphoma, and they ask what would be expected. The answer should be increased lifespan of population of cells makes sense since anti-apoptotic molecule. Okay. BCR-ABL. High yield for chronic myelogenous leukemia, CML, T922 translocation of the two genes, aka Philadelphia chromosome, codes for a fusion protein. This fusion protein is an oncogenic tyrosine kinase. Chronic myelogenous leukemia is the answer for leukemia when the question gives you lots of myelo-sounding cells, i.e. myelocytes, promyelocytes, metamyelocytes. 4 to 5 questions on USMLE that mention these cells are CML. Leukocyte ALP will be low. The blood smear for CML I refer to as a motley mix or soup. This is a buzzy image on NVMe for CML. Imitamib is a treatment for CML. It can cause a fluid retention / peripheral edema. The mechanism of action of imitamib is targets BCR-ABL tyrosine kinase. BRAF, or BRAF, proto-oncogene that can be seen in some melanomas, codes for serine threonine kinase. BRCA1/2, the BRCA1, BRCA2. The breast cancer tumor suppressor genes, NBME, exam asks for what the gene does. The answer should be recombinational double-strand DNA repair. Can also lead to gynecologic cancers in females or breast/testicular cancers in males. Answer on NBME exam for appropriate prophylaxis in patient who has confirmed mutation is bilateral oophorectomy and mastectomy. c-KIT, proto-oncogene, can be mutated in some gastrointestinal stromal tumors, GIST. c-MYC, overexpressed in Burkitt lymphoma, a type of NHL as a T8 to 14 translocation, codes for a transcription factor. Oh, and it's continued right here. So we're still on c-MYC right now. c-MYC for Burkitt lymphoma. Burkitt lymphoma will be a mass of the jaw or the abdomen. Histology is buzzy for starry sky appearance, which is a basophilic purple background of B cells, which are scattered translucent macrophages. The macrophages are referred to as a tingible body macrophages, correct, not tangible, tingible. When apoptosis occurs, this is asked on the NBME exam where they have an arrow that points to one of the macrophages, and the answer is apoptosis. EGFR, non-small cell lung cancer, adenocarcinoma, and glioblastoma multiforme. Codes for EGFR tyrosine kinase. Erlotinib, asked on USMLE, targets EGFR tyrosine kinase. HER2-neu, or ERBB2, the tyrosine kinase expressed in some breast cancers. If positive, leads to poor prognostic indicator. Trastuzumab, Herceptin, is a drug that targets HER2/neu. It can cause cardiotoxicity. JAK2 can be activated in polycythemia vera, essential thrombocytosis, and myelofibrosis. USMLE wants increased proliferation of hematopoietic stem cells, not pluripotent stem cells, for PV. For PV, what does that mean in this context? PV. Polycythemia vera, okay. Patients will have high RBCs plus either high white blood cells and or platelets, that is to say 2 to 3 of the cell lines will be high in questions, but the RBCs are always high. Generalized pruritus after showers can be seen from basophilia, hyperviscosity syndrome, blurry vision, headache, Raynaud's phenomenon from high RBCs is treated with phlebotomy. Hydroxyurea can decrease recurrence of episodes. Essential thrombocytosis will present with questions as platelets over 1 million, normal range is 150,000 to 450,000. They will say that there's a pain or dislocation in tips of fingers, or give hyperviscosity type findings. Bone marrow will show, that's great. Bone marrow will show increased megakaryocytic proliferation. This latter finding will not be seen in reactive thrombocytosis, which is high platelets from infection. Myelofibrosis will present with teardrop-shaped RBCs or dacrocytes and or dry tap on bone marrow aspiration. Massive splenomegaly is seen in basically all questions, though. What about KRAS? I always think it looks like the word crass, but it's pronounced, I guess they call it KRAS. Proto-oncogene codes for the GTPase. The answer on USMLE for the first gene mutated in colonic polyps prior to the progression to the colon cancer. Colon cancer often develops as a result of progressive mutations rather than one mutation straight up. In other words, first it's KRAS, and then it's P10, and then DCC, and then TP53. But it starts usually with KRAS, right? That's what you start off with colonic cancer. If they tell you that the colon cancer has metastasized and force you to choose a gene that's mutated, then go for TP53, codes for P53 protein. So if you have to choose one that has happened by the time metastasis has occurred, choose TP53. But a lot of times the first one to go out is the KRAS one. If they tell you that the polyp is seen to have no evidence of invasion or stalk, choose KRAS. This is on NBME exam. So what they're saying is, if it's already metastasized and you have to choose one gene, TP53. But if it's not metastasized yet, choose KRAS. The first thing that's most likely to mutate before anything else does, probably KRAS for colon cancer. MEN1. Mutations cause multiple endocrine neoplasia type 1, 3Ps, pituitary tumor or prolactinoma, parathyroid adenoma or diffuse foregut hyperplasia, and pancreatic tumor, gastronoma, Zollinger-Ellison syndrome. High yield point is that NBME questions need not to give all the findings within the MEN syndrome. For example, the question can give gastronoma alone and ask for the gene MEN1. MSH2/6 MLH1. Hereditary non-polyposis colorectal cancer, HNPCC. Mismatch repair genes, mutations cause microsatellite instability. Let us continue. Okay, PSM2, colonic polyp/cancer, also associated with gynecologic cancer. NF1, neurofibromatosis type 1, chromosome 17, autosomal dominant. Cafe au lait spots, hyperpigmented macules, axillary groin freckling, neurofibromas, nerve sheath tumors presenting as nodules under the skin, weird CNS tumors, that is to say oligodendroglioma, ependymoma, meningioma, optic glioma, CN2, cranial 2 tumor. Classic disease that demonstrates variable expressivity, which means varying disease severity. I talk more about this stuff in my high-yield genetics PDF. NF2, neurofibromatosis type 2, chromosome 22, autosomal dominant. So it's not even the same chromosome. Bear that in mind as well. Presents with the acoustic schwannoma, can be bilateral, and a meningioma. RB, congenital retinoblastoma, name gives it away, retinoblastoma, RB. Congenital retinoblastoma, i.e. leukocoria in the first 1-year-old, and osteosarcoma. Tumor suppressor gene, autosomal dominant, 2 hits required, but chance of a second mutation is 100%, so it's autosomal dominant, not autosomal recessive. Okay, so it's saying it takes 2 hits to actually have it. It's autosomal dominant because 2 hits are required, but the chance of the second mutation happening is 100%. So even though it's in a very, very, very technical way, it's autosomal recessive. Functionally speaking, it is autosomal dominant because the likelihood of you getting the second mutation is very, very high. RB protein is normally in a complex of E2F, a transcription factor, repressing it and preventing cell cycle progression. CDK cyclin complexes then phosphorylate RB, releasing it from the E2F. E2F then goes out to the nucleus and transcribes genes, leading to a cell cycle progression. NBME simply wants you to know that the decreased RB phosphorylation is a wrong answer for what you'd expect in cancer cells. RET. This is relevant. RET, proto-oncogene, MEN2A, 2B. MEN2 syndromes have pheochromocytoma and medullary thyroid carcinoma. MEN2A has a parathyroid adenoma or hyperplasia, same as MEN1. MEN2B has a marfanoid body, habitus, and mucosal neuromas. Same as with MEN1, at a high yield point is that NBME questions need not give all the findings with a MEN syndrome. For instance, one NBME question just gives you medullary thyroid carcinoma alone, and the answer is RET. Another gives a groin pain, urolithiasis due to hypercalcemia, plus a neck tumor, and the answer is RET. So they could be kind of roundabout how they describe it, you know. So they call it MEN1, MEN2A, MEN2B. I'm trying to figure out what's the actual abbreviation for that for, because it's RET gene, you know. So MEN2A. It's called that multiple endocrine neoplasia. So it's called that because of multiple endocrine neoplasia. This is why it's called MEN. Okay, I'm going to take a brief break and come back to you. Okay, TP53. This is an important one. TP53 codes for the p53 tumor suppressor protein, halts the cell cycle in the setting of a cellular damage so the DNA repair can occur. Li-Fraumeni syndrome, congenital mutation in TP53 leading to cancers of various organ systems. High yield answer on NBME for the gene mutated in cancer that is metastasized. Pleiotropy, one gene has multiple effects. TP53 is a textbook example since mutation can cause many ulcerated cancers such as pancreatic, ovarian, colon, etc. TSC1/2, autosomal dominant, hamartin and tuberin proteins, intellectual disability, paraventricular nodules, tubers, adenoma sebaceum, aka angiofibromas, which are skin-colored reddish papules on cheeks, nose, and nasolabial folds, subungual fibromas, nail bed tumors, cardiac rhabdomyoma, ball and valve, murmur that presents as a diastolic rumble that attenuates with change of positioning, renal angiomyolipoma. What about VHL? This VHL, the name should give it away, right? Autosomal dominant chromosome 3, renal cell carcinoma, plus retinal and or cerebellar hemangioblastomas. It's called von Hippel-Lindau syndrome. So it's VON, von, Hippel, Hippel, I believe, and then Lindau, I think, is Lindau, I think it's German. So von Hippel-Lindau syndrome was related to VHL gene. Renal cell carcinoma plus retinal and or cerebellar hemangioblastomas. Pancreatic cysts can also be seen on NBME. The RCC, renal cell carcinoma, need not be bilateral. Do not confuse with angiomyolipoma of the TSC. New NBME question gives you a gross kidney lesion plus you patient has a cerebellar hemangioblastoma, retinal angioma, and they ask you what kind of kidney lesion you're showing. The answer should be renal adenocarcinoma. The angioma was the wrong answer. You go for renal adenocarcinoma. Let me just confirm something. Von Hippel-Lindau syndrome. Yeah, I mean, this is the thing. I looked it up. They don't mention the word von Hippel-Lindau in the PDF at all, but von Hippel-Lindau syndrome is a rare inherited genetic disorder affecting about 1 in 36,000 people. It's caused by the mutation in the VHL tumor suppressor gene, leading to the growth of both non-cancerous cysts and cancerous tumors in multiple organ systems. So they're talking about it from a very acute perspective, I guess, talking about like the kidneys and stuff. Oh, they're talking about hemangioblastoma as well. So I wouldn't say that exactly, but they don't like, for some reason they don't want to say that it's the actual VHL syndrome. They just say VHL, and you're supposed to, I guess, I don't know, just intuit that. I don't know. I'm not sure what they're going for. So WT1 can be isolated Wilms tumor. The answer on USMLE for a kidney tumor in a kid almost always presents as a painless flank mass in a 2 to 4 year old. However, Wilms tumor can also present as a part of the constellation syndromes. Dennis-Drash syndrome, gonadal agenesis plus Wilms tumor. Wagner syndrome, Wilms tumor, aniridia, genitourinary abnormalities, retardation can be associated with other genes as well, but just know that WT1 is associated with it. Beckwith-Wiedemann, so a lot of things are associated with this. So Beckwith-Wiedemann, or Wiedemann syndrome, fetal macrosomia, macroglossia, hemihypertrophy, hypoglycemia, and Wilms tumor. Harder question on 2CK form gives a big baby and hemihypertrophy. It does not mention a Wilms tumor. They ask you what it could be. The answer should be hypoglycemia. So that's a little bit annoying, but okay. But the names should help you figure out what's going on. So WT1, think about Wilms tumor, right? WT, Wilms tumor. VHL, von Hippel-Lindau syndrome. TSC1 gene causes what exactly? Let's see what the name they actually use. TSC1 causes what? It should cause something that's probably TSC, tuberous sclerosis complex. Okay, see, that's what I was thinking. It's going to be something like that. So remember, TSC1, tuberous sclerosis complex. And this, what they're describing in the book here is kind of what that relates to. Von Hippel-Lindau syndrome, sort of a similar situation. Wilms tumor, similar situation. VHL, WT1, respectively. So bear that in mind. Also, we're in 341 right now. We made a little bit of progress. Other high-yield genes. ATP7B, Wilson's disease, autosomal recessive, chromosome 13, copper overload, inability to secrete copper into bile from the liver. The copper is normally excreted by the body via the secretion into bile. Elevated urinary copper plus a decrease in the serum ceruloplasmin, copper-binding protein in the blood. In the case of copper overload, body tries to minimize the amount carried in blood. Buzzy/pass level detail is the Kaiser-Fleischer rings, which is the copper deposit in the cornea of the eye. The vignette can give you what sounds like Wilson's disease, and then the answer is slit lamp exam. Can cause an elevated LFTs with cirrhosis, hemolytic anemia, and Parkinsonism. The copper deposits in basal ganglia, especially the putamen. Parkinsonism in a young patient means Wilson's disease until proven otherwise. In other patients, Parkinsonism equals Parkinson's disease, normal pressure hydrocephalus, Lewy body dementia, or progressive supranuclear palsy. But in young people, think about Kaiser-Fleischer. When you see the Parkinson-like symptoms, think about the actual Wilson's disease and therefore the ATP7B gene. What do you do if you have Wilson's disease? You treat with copper, chelator, penicillamine. So penicillamine. What about CFTR? CFTR, cystic fibrosis, chromosome 7, AR. Autosomal recessive. Codes for chloride channel. Channel is normally located at the cell surface. If mutated, it instead remains sequestered in the rough endoplasmic reticulum. Abnormal protein folding is the answer on NBME for result of CFTR mutations. Delta F508. Delta F508 is the most common mutation, which is deletion of the phenylalanine 508. The cystic fibrosis is a textbook example of an allelic heterogeneity. An allelic heterogeneity with my mind is losing it, I guess. Cystic fibrosis is a textbook example of allelic heterogeneity, which means many different mutations can cause the same disease. For this reason, most genotyping panels lack sensitivity, and sweat chloride testing showing a greater than 60 milliequivalents is most diagnostics less accurate, because again, the gene mutations are everywhere, so it's not necessarily going to be great to use that as a first go-to for determining what's going on. It's better to just use the diagnostic criteria from chloride sweat testing. Okay, a nasal test showing increased potential difference can also be performed. Presents as a child with chronic history of lung infections. Pseudomonas exceeds Staph aureus after the age of 10. Secretions in the alveoli and pancreatic ducts are inspissated, meaning desiccated/dried up within the lumen, making them sticky. This leads to exocrine pancreatic insufficiency, where enzymes cannot make it to the duodenum, leading to fat-soluble vitamin malabsorption, which leads to NVMe exams love vitamin E deficiency, and cystic fibrosis in particular presents as neuropathy. Meconium ileus at birth, buzzy but often not mentioned in questions. Phenotypically normal siblings of affected children have 2/3 chance of being carriers, holds true for any autosomal recessive disorder. Ivacaftor/lumacaftor are new treatments. They are, is that lumacaftor or iumacaftor? I don't know. Ivacaftor. Are newer treatments. They are known for potentiators/correctors, where the chlorine channel structure, location, and function are improved. Okay. I'm going to take another break again. I am back from my hiatus. We are back. DMD. X-ray disorder caused by mutation in dystrophin. Mutation results in disruption of an alpha-beta dystroglycan, which is required for proper internal cytoskeletal anchoring of the muscle cell to the extracellular matrix. Presents with pseudohypertrophy, where the muscle appears large but are replaced with fibroadipose tissue, connective tissue from stromal cells. Connective tissue stromal cells, okay. Duchenne presents in a young boy. Also, by the way, this disease is Duchenne's muscular dystrophy, DMD. And this is the gene is DMD. Duchenne's muscular dystrophy presents with a young boy who implements Gower maneuver to stand up, uses arms to walk up off the floor because his leg muscles are weak. Becker presents in adolescence or young adulthood, less severe form of Duchenne's. Duchenne's is classically frame-shift mutation. Becker is classically a non-frame-shift mutation, which is why Becker is not as severe. FBN 1 and 2, Marfan syndrome, autosomal dominant chromosome 15, codes for fibrillin, hence the name FBN, which is a glycoprotein that forms a sheath around elastin. Tall, lanky body habitus with flat feet, chest wall deformities, that is to say pectus excavatum or carinatum, flat feet, pes planus, scoliosis, mitral valve prolapse, mesosolic click, increased risk for aortic dissection, can retrograde propagate toward aortic root, causing a root dilation and aortic regurgitation, decrescendo diastolic murmur. It is not associated with barysacular aneurysms, unlike Ehlers-Danlos and ADPKD, which is adult. I think it's is it autosomal dominant, or does that mean adult onset? Well, adult type. I'm not sure. I think it means autosomal dominant. ADPKD. It means autosomal dominant polycystic kidney disease. Okay. So I will go and make a little note for myself right here. We're going to call it. We're going to explain what the name means, why it's called that. So this is FBN1. So we're just going to put the word fibrillin here, and for DMD we're going to put Duchenne's. We're going to make this small. I might do the other ones later when it becomes relevant. Okay. FMR1, fragile X-linked, causes CGG trinucleotide repeat of the TNR expansion. Results in hypermethylation of the gene and transcriptional silencing. Presents as a boy with large everted ears, long narrow jaw, macroorchidism, and intellectual disability. Can sometimes be symptomatic in females if skewed X inactivation or lionization. Okay, so it's going to present in boys because they only have one X chromosome, but in females it will be maybe not as pronounced, but it can be symptomatic potentially. Let me look that up. Fragile X symptoms. I've never heard that one before. Okay, they say, high anxiety, hyperactivity, enlarged testes. I'm going to say testes for that word right there in the males after puberty. So it's So it's not that their phallus is large. Maybe it is. I don't know, but it's not so much that the phallus is large as much as the actual testes are large. Are they infertile? Cause infertility. Can cause infertility challenges, specifically leading to fragile X-associated primary ovarian insufficiency. So for women, it could cause some issues, apparently. in some women and potentially reproductive issues in men. However, it does not always cause complete sterility, and many carriers still have children. Okay, interesting. This is a detour, but I'm just curious. Why does let's see. Why does it cause hyperorchidism? Fragile X syndrome causes hyperorchidism with abnormally large testes because the mutated gene limits the production of crucial regulatory protein. This protein normally keeps cell growth in check, and its absence leads to an overgrowth of testicular tissue. Okay, so basically, one of these regulating proteins does not function correctly. As a consequence, they just continue to get larger, I suppose. Bigger than they're supposed to be. How odd. FXN. Friedreich's ataxia, frataxin gene, GAA TNR expansion, presents with ataxia, you guessed it, scoliosis, cardiomyopathy, and decreased reflexes. G6PD. Glucose-6-phosphate dehydrogenase deficiency, X-linked recessive, presents as boy with hemolysis to jaundice, leading to jaundice, unconjugated hyperbilirubinemia, followed by oxidizing drug, that is to say sulfadapsone and primaquine, Heinz bodies, denatured hemoglobin, and bite cells, degmocytes, partially phagocytosed RBCs due to the removal of Heinz bodies are seen. HFE. Hereditary hemochromatosis, autosomal recessive, chromosome 6. Iron overload. Mechanism USMLE wants is increased intestinal iron absorption. Body has poor ability to excrete iron, occurs naturally via menses in women, otherwise there are minor losses via skin shedding. Main iron regulation is via shutting off intestinal absorption. This is impaired in hemochromatosis. Usually presents in adulthood in males first, because of menses in women. Can present as bronze diabetes, leading to hyperpigmentation due to hemosiderin deposition in the skin, plus elevated fasting sugars, iron deposition in tail of the pancreas. Miscellaneous other findings can be seen like infertility, like iron deposition in hypothalamus, anti-pituitary or gonads, cardiomyopathy, or arthritis, pseudo-gout. Hereditary hemochromatosis. Hereditary hemochromatosis, primary hyperparathyroidism, and hypothyroidism are three of the most important causes of pseudo-gout. I used to only discuss the former two with students over the years, but the latter shows up on the new 2CK NBME exam where the mentioned chondrocalcinosis, calcium deposition in cartilage. USMLE wants you to know that there is an elevated risk of hepatocellular carcinoma. There is an easy NBME question of hemochromatosis where they ask the patient is at an increased risk for, and the answer is simply hepatocellular carcinoma. Diagnosed with ferritin greater than 300 mg over DL, transferrin saturation will also be clearly elevated. It is exceedingly rare that the ferritin is greater than 300 in other conditions. However, this can occur in lymphoma and leukemia where the elevated ferritin is a poor prognostic marker in non-Hodgkin lymphoma. There is one NBME question on 2CK where the ferritin is 300 where it's not hemochromatosis, but the USMLE won't play gotcha. Again, typically it will be the hemochromatosis, the hereditary hemochromatosis. Treat with the serial phlebotomy, not chelators. Chelators such as deferoxamine or deferocerox are for secondary hemochromatosis due to the transfusional siderosis, that is to say, repeated blood transfusions that contain iron for beta thalassemia major. And the point behind that is that if you're getting lots of iron transfusions because you have beta thalassemia, you're going to have this iron overload potentially. Makes sense? Because you're doing these transfusions of iron. HTT. Huntington's disease, autosomal dominant, CAG TNR expansion of chromosome 4, presents as a cognitive decline and chorioathetosis, usually in patients' 30s and 40s. Chorea means fast, purposeless, jerky movements, but athetosis means slow, riding movements. TNR disorders demonstrate, just for reference, can I just get a reference right now, TNR disorder? Trinucleotide repeat. So trinucleotide repeat disorders demonstrate anticipation, which means that they become more severe and earlier onset with each generation due to further expansion of the TNR. So the vignette can say that the 40-year-old patient had a parent with similar symptoms appearing in his 50s. If the patient USMLE asks you for which part of the brain is messed up, choose the caudate nucleus for Huntington's disease. NFKB1/B2 codes for the NF-kappa B protein, which is involved in a myriad of cell signaling processes. For whatever magical reason, why is he always magical reason? A repeated question on across NBME exams wants you to know that the I-kappa B, like I-kappa B, releases NF-kappa B after undergoing phosphorylation. NF-kappa B is then free to go to the nucleus to upregulate transcription of the 150 plus genes. Glucocorticoids, that is to say, such as prednisone, partially exert their immunosuppressant effects by inhibiting the NF-kappa B mediated gene expression. PKD1/2, autosomal dominant polycystic kidney disease. The answer on USMLE if the disease starts as an adult, i.e. 30s and 40s. Cysts are technically present early in life, but only become clinically irrelevant as an adult, i.e. elevated blood pressure and elevated RFTs. Basically, you have the cyst continue to develop as time progresses, but you don't notice the problem until it's in your 30s or 40s. And at that point, it looks quite ugly. You should go look at a picture of one of these polycystic kidney disease issues. These patients have an elevated blood pressure due to the increase in RAS, compression of the microvasculature of kidneys due to the enlarging cysts, can cause saccular berry aneurysms of the circle of Willis, risk of subarachnoid hemorrhage. Highest yield point is that the serial blood pressure checks are correct over circle of Willis. Sorry. It says highest yield point is that the serial blood pressure checks are correct over the circle of Willis MR angiogram screening. Latter is wrong answer on USMLE. MR angiogram screening of circle of Willis is only done when there is a positive family history of SAH or saccular aneurysms. Cystic kidneys are part of the ciliopathies, which is an obscure term that refers to conditions where the cilia are abnormal. Polycystin is a protein required for cilia function on renal epithelium. Most common extrarenal location for cysts is the liver, 85% by age 30. Let me underline something. Can I underline directly, or do I have to do something different? Let me do this. Let me check this out. Because I just want to underline. Well, I could just why underline? I can highlight. That's probably better. Why am I doing that? Because I just want to have the word, the disease, right on your face. Same thing with this. Let me go back to here. Where was I? Yeah, anyway, so PKHD1, autosomal recessive polycystic kidney disease. The answer on USMLE for cystic kidneys in pediatrics can be associated with hepatic fibrosis. So we're 42 minutes in. I'm going to take another break, I believe, and I'll come back to you. I think. We're pretty close to done, to be fair, but I'll take a short break. Maybe. Okay, let us continue. Notable tumor markers: AFP, alpha-fetoprotein, yolk sac tumor, aka endodermal sinus tumor. The answer in USMLE for a testicular or ovarian tumor in a child. Mixed germ cells tumors if human chorionic gonadotropin also high. ALP, alkaline phosphatase. Placental ALP can sometimes be increased in seminoma, unrelated to increased ALP in bile duct obstruction or bone fractures. CA15-3, breast cancer. CA19-9, pancreatic cancer. Calcitonin, increase in medullary thyroid carcinoma. Normal role of calcitonin is to inhibit the osteoclast activity. CEA, carcinoembryonic antigen. Colon cancer, although non-specific. Human chorionic gonadotropin. Human chorionic gonadotropin. HCG, right. Choriocarcinoma, mixed germ cell tumors if AFP also high. LDH, lactate dehydrogenase, dysgerminoma. PSA, prostate-specific antigen, prostate cancer. Makes sense. Hypersensitivity type relevant points. Type 1, immediate within minutes, antigens bind. This is kind of a detour, but sure. Hypersensitivity type relevant points, mechanism, and then type 1. Type 1, immediate within minutes, antigen binding to binds to Fab region of the IgE on the mast cell. Adjacent IgE crosslink, mast cell degranulates and secrete histamine plus tryptase. Late, within hours, cytokines release inflammatory cells, that is to say, eosinophils. Further inflammation. High yield examples are anaphylaxis, i.e. bee sting, peanut allergy, atopy/asthma. Type 2, antibody production against cells, tissues, and receptors. High yield examples are Graves' disease, Hashimoto's thyroiditis, Goodpasture syndrome, pernicious anemia, HIT, ITP, rheumatic fever, myasthenia gravis, Lambert-Eaton, bullous pemphigoid, and pemphigus vulgaris. Type 3 hypersensitivity, antibody-antigen complexes, that is to say, antibodies simply bind to antigen and deposit. The antibodies do not target cells, tissues, or receptors. High-yield examples are post-streptococcal glomerulonephritis, post-polyarteritis nodosa, systemic lupus erythematosus, arthritis reaction, and serum sickness. Type 4 hypersensitivity, T-cell response, only hypersensitivity type not associated with antibodies. That's very important. Type 4 is the only type that's not associated with antibodies. Can be mediated by either CD8 positive or CD4 positive T cells. High yield examples are PPD, skin test for TB, contact dermatitis, graft versus host disease. Notable carcinogens: alcohol, oral/pharyngeal squamous cell carcinoma of the esophagus, hepatocellular carcinoma, breast cancer. Aflatoxin, answer on USMLE if they mention peanut farming in China, okay, can cause hepatocellular carcinoma. Aniline dyes, answer on USMLE for hematuria and textile factory worker, can cause transitional cell carcinoma, TCC, of the bladder. Aniline dyes are a type of industrial clothing dye. Arsenic, answer on the USMLE for Mies lines, white lines of the nails, or palms plus soles rash in a gardener. Arsenic is in many fertilizers. A small amount causes plants to flourish, poisoning seen in gardeners/landscapers clearly. A 2CK NBME question gives a pic of a Mies lines in gardener. The answer should be arsenic. Asbestosis, restrictive lung disease with ferruginous bodies and supradiaphragmatic pleural plaques, can develop into mesothelioma. NBME question shows a pic of ferruginous bodies and asks what the cell initiates pulmonary fibrosis. The answer should be macrophage. The pleural/supradiaphragmatic plaques can be described simply as soft tissue densities seen on chest X-ray. Mesothelioma can lead as whitish cancer that circumferentially envelops the lungs. NBME question asks for mesothelial cells as the answer. Shipyard workers, construction workers, and electricians are buzzy professions on USMLE for asbestosis. Benzene, causes leukemias. Ethanol, highest yield esophageal squamous cell carcinoma, so alcohol we're talking about here, plus hepatocellular carcinoma. Breast cancer carries theoretical association, but USMLE does not care. Ionizing radiation, thyroid cancer, leukemias. 2, naphthylamine, main compound in some types of mothballs. Collecting duct cancer on NBME. I also discuss this more on high yield renal PDF. Nitrosamines, gastric cancer associated with elevated consumption of cured meats. It's kind of like smoked meats, basically, as far as I'm aware. Processed meats, colorectal cancer. Radon, adenocarcinoma of the lung in non-smokers, due to background radiation from the ground, considered a second most important cause of lung cancer after smoking. Wait. Radon causes the second most important cause of lung cancer after smoking? Are you serious? Okay. Smoking/tobacco, basically every cancer. UV light, skin cancer. Vinyl chloride, hepatic angiosarcoma. So some of those are more obvious than others, but just be aware of that. That's pretty comprehensive, I would say, in terms of all the different things that can cause cancer. Well, I mean, obviously there's a lot more than just that, but those are pretty good. That's a pretty good go-to list. Notable paraneoplastic syndromes. Gastric. Acanthosis nigricans should be noted that almost always this finding simply means insulin resistance, but just be aware it can also be associated with visceral malignancies like gastric. Visceral malignancy is a general term that refers to main organ system cancers like the liver, pancreas, stomach, etc. Sign of lesser Trellat, I don't know. Sudden appearance of large numbers of seborrheic keratoses can occur with vesical malignancies like gastric and pancreatic. Virchow node, Toisier sign, is a palpable supraclavicular lymph node that is classically associated with gastric cancer, but can be visceral malignancy in general. There is also a 2CK NBME question where the Virchow node present in a Hodgkin. Ovarian. Ovarian can cause dermatomyositis. Weird, but that's an NBME question. Pancreatic, migratory thrombophlebitis, Trousseau sign on malignancy. Renal cell carcinoma, RCC. Hypercalcemia, PTHRP, which is PTH or parathyroid hormone related protein secretion, same as squamous cell of the lung. Polycythemia, EPO secretion. Is that right? I checked this before, I believe that. I forgot which one was correct. PTHRP. Related protein, yes. So where was I? Okay. Next one. Lung cancer general. Hypertrophic osteoarthropathy, clubbing plus periostitis. Periostitis is inflammation of the periosteum over the bone, classically associated with adenocarcinoma of the lung, but the USMLE does not specify. They'll just give you a vignette of clubbing plus hand pain, and the answer is just X-ray for the next best step in management. Neuroblastoma, opsoclonus, myoclonus syndrome, dancing eyes. Small cell carcinoma of the lung, Cushing syndrome, ACTH secretion, SIADH, ADH secretion. Lambert-Eaton syndrome, antibodies against presynaptic voltage-gated calcium channels, cerebellar dysfunction /ataxia, anti-WHO/YO antibodies. Okay, squamous cell carcinoma of the lung, hypercalcemia/hypophosphatemia, PTHRP secretion. PTHRP, again that's parathyroid hormone-related protein, is not the same as the endogenous PTH, which is suppressed due to the negative feedback loop from high calcium. So basically, PTHRP resembles PTH. It has a similar effect to PTH. The body will react to it as if it was PTH, including suppressing native PTH production, but it is not the same thing as PTH. And so when you look at the actual PTH levels, it will say low PTH. You say, how could that be? We have all these sort of PTH-related symptoms that are, whatever. And the answer is because it's not actually PTH. It's just PTH-related protein. Thymoma, myasthenia gravis, antibodies against postsynaptic nicotinic acetylcholine receptors. Do chest X-ray / chest CT in patients with myasthenia gravis. Thymoma can also rarely cause a pure RBC aplasia, that is to say, only RBCs are down. locations of metastases. Metastasizes to cancer type. Spine/vertebrae. Prostate cancer and lung cancer all love to metastasize to spine/vertebrae. I've seen this across the NBME questions, and especially on 2CK Neuro CMS questions, where they'll give neurologic findings in patients with cancer and want epidural spinal cord metastases or epidural spinal cord compression or metastases to cauda equina on its answers. There's an NBME question where they give you lytic lesions of the vertebrae in a vague 1 to 2 liner, where the multiple myeloma is not listed, and they just want metastatic breast cancer as the answer. One of the highest yield general principles for USMLE is that the prostate cancer causes osteoblastic metastases, which means that they light up on a bone scan. Pretty much all the other cancers that cause osteolytic metastases. Again, prostate cancer is osteoblastic, which is unique, or is distinguishing, I should say. Occasionally, some cancers, such as breast cancer, I'm not sure if there's any other osteoblastic cancers, but that is not a common thing. And typically, it's osteolytic, the other way around, right? Occasionally, some cancers, such as breast, can cause osteoblastic metastases. As I was saying, it might not be just exclusive to that, but it is probably likely to be prostate cancer in that case. But for the USMLE, this application is essentially non-existent. Just remember the prostate for this point. So basically, if you see osteoblastic metastases for bone and it lights up, it is very, very likely to be prostate cancer. If you're thinking cancer, anyways, right? Lung/brain. Choriocarcinoma loves to go to the lung and brain. If they give you a gynecologic question plus mention the pulmonary nodules or stroke-like presentation, this is high yield for choriocarcinoma. Hydatidiform mole is a wrong answer here because even though there is a ladder can progress to invasive mole and choriocarcinoma, if the question itself already mentions pulmonary or neuro findings, we know that they already have the cancer, so choriocarcinoma is the best answer. So go for choriocarcinoma because they already have the cancer. Ovaries. Gastric cancer can metastasize hematogonously to ovaries. These are called Krukenberg tumors, and they will have signet ring cells in biopsy, which contain mucin. Omentum. USMLE loves direct extension to the omentum for ovarian cancer. There are 2 questions in the 2CK NBMEs where they say omental thickening and omental caking. Para-aortic lymph nodes. Testicular and ovarian cancers. I discussed specific lymph node drainages of cancers in my high-yield immuno PDF, but this one is most important, so I'm including it here. Okay. Malignancy-associated microbes. Aspergillus. Fungus that can produce aflatoxin, which increases the risk for hepatocellular carcinoma. Clonorchis sinensis, trematode or fluke, a type of helminth parasitic worm, can cause cholangiocarcinoma, cancer of the bile ducts, treated with praziquantel. Epstein-Barr virus, EBV, causes nasopharyngeal carcinoma and B-cell lymphomas, Hodgkin and non-Hodgkin lymphoma. Helicobacter pylori causes mucosal associated lymph tissue malt lymphoma or maltoma, a type of B-cell lymphoma. Hep B/Hep C, hepatocellular carcinoma. HHV8, Kaposi sarcoma, which is associated with HIV patients, particularly, what's the term for it? Men who have sex with men. You have this situation with Kaposi sarcoma. Kaposi sarcoma, I should say. HIV, primary CNS lymphoma at CD4 counts generally less than 100 microliters. Immunodeficiency in general can increase the risk of squamous cell carcinomas, that is to say, anal squamous cell carcinoma and MSM. Again, what does MSM mean? Men who have sex with men. Esophageal squamous cell carcinoma and smoking/alcohol. Squamous cell carcinoma is skin due to sunlight. NBME questions can occasionally mention immunodeficiency to questions to imply squamous cell carcinoma. HPV 16/18, squamous cell carcinoma, usually genital or anal. HTLV, human T-cell lymphotropic virus, can cause cutaneous T-cell lymphoma, mycosis fungoides, and T-cell leukemia, Sézary syndrome. Schistosoma hematobium, trematode, squamous cell carcinoma of the bladder, patient who swam in a lake in Africa. Do not confuse with transitional cell carcinoma of the bladder, which is smoking, aniline industrial dyes, and 2-naphylthylamine mothballs. Different thing. It causes squamous cell carcinoma, not transitional cell. Strep bovis can increase the risk for colorectal cancer, CRC, and endocarditis in setting of CRC. And that is the end of our general pathology section. For me, I think there's a lot of interesting content in there. I think it might be of utility. It feels a little bit like it's just trying to round up everything they didn't talk about anyways, because this is one of the last chapters, and maybe they're like, oh, we have to have this stuff in here somewhere, Or I don't know. To be fair though, there is a degree of systemization to it, where they say, okay, here's all of the cancer-related stuff here. Here's all of the stuff related to this stuff here. Here's all the toxins you need to know. It feels sort of like a clinical education chapter or something, right? They just kind of give you a general overview about all the big hitting toxins and all the big hitting genes. Well, that's more like whatever. You get my point. It's not super specific to a particular topic. It's kind of all over the place to some degree, and I'm not sure if they're doing that because it's just a concept in and of itself, or they feel like they need to kind of cover all their bases in what they have not covered in the other chapters. But regardless, that's the end of the chapter. So hopefully it was of good use to you, regardless of what might be your particular opinion as to what it's supposed to serve. I think the purpose, regardless, is education of the doctor in training, or it's to be doctor, I guess you could say. So hopefully it was of good use to you. Regardless, have a great rest of your day. Thank you.